So today I'm going to discuss yet another case for the Mrcp PACES consultation station, and I'm going to talk a bit about dermatomyositis. So let's start our presentation. So this is a patient profile. Mr. John Smith, a 45-year-old man, presents with a 3-month history of progressive muscle weakness and a rash. So as this is a consultation station, so you have to take the relevant history. I have put some relevant history points here. Patient has presented with progressive muscle weakness and a rash. So you must think about all the differential diagnosis before you enter the station, and it will be wise to maybe make a plan how you're going to proceed with your history and examination, considering the differential diagnosis in your mind. So relevant history points, we want to know about the symptom onset and duration. When did the symptoms started? Any specific triggers or gradual onset? Regarding the muscle weakness, we want to know about the extent and progression of muscle weakness. We will be interested in knowing if there's any difficulty with daily activities like climbing stairs or lifting objects. This will give idea more about the proximal weakness. Skin rash, we want to know about the appearance, location, and progression of the rash and any associated symptoms like itching or pain. We like to inquire about any systemic symptoms as well, including any fever, any weight loss, fatigue or joint pain, any difficulty swallowing or changes in appetite. Then we want to do the systemic review. So we're going to ask about the respiratory symptoms like any shortness of breath or coughing, cardiac symptoms like chest pain, palpitations or edema. Does sun exposure worsen the rash or symptoms? Any recent medication changes or new medications? And finally, about the family history, any family members with similar symptoms or autoimmune disease. So remember these headings and try to take the complete history as much as possible. And always in the consultation station, start with an open-end question. Like in this case, you can ask, you introduce yourself and then you take consent. I like to ask few questions regarding your symptoms, and then you can start with the whatever information is available to you. So you can start with then that I know that you have a 3-month history of progressive muscle. You have a muscle weakness. Can you tell me more about it? So patient will volunteer all the information which he or she is allowed to give you without any prompt. And then obviously you have to prompt and dig out the history. This is about the history. Then after that, we want to do the relevant examination. So as this is the patient gives a history of a weakness, so we want to assess for any proximal muscle weakness, any muscle tenderness and atrophy. Obviously going to start with the inspection, going to palpate for any tenderness, and then you go look for the power in the upper and lower limbs to check for any proximal muscle weakness. Skin examination is important. We look for the characteristic findings, and these are heliotrope rash, which is purplish discoloration on the eyelids. Here I have put one picture here. So this is something called heliotrope rash, and you can see some purplish discoloration of the eyelids here. And then we can look for any Gottron papules, and while you're doing the examination of the hands, and this you can see the hair. I put a picture here. These are raised, bumpy, scaly bumps over knuckles. So here you can appreciate that one. You can see here there we have got some rashes on the knuckles, and look for any erythema over the face, neck, and upper chest, which is called shawl sign. So then we're going to, after doing the muscle examination, skin examination, we want to do the systemic examination as well, considering the other complications for the dermatomyositis. So evaluate for any signs of interstitial lung disease. So we want to auscultate the lungs to look for any fine crackles, and then we also want to do the cardiac examination as well to look for any signs of murmurs or any signs of heart failure, and as well as the look for any joint inflammation. And neurological examination, I think not much be needed, just briefly look for any focal neurological deficit. So this is how you're going to proceed with the examination in this case. Mainly focusing on the patient symptoms, looking for the weakness, and then don't miss the specific signs on the skin examinations like these Gottron papules and heliotrope rash, because these are quite pathognomic or quite characteristic features of dermatomyositis. Okay, so what are the differential diagnoses we are considering? We're thinking about, on the top of the list, we're thinking about dermatomyositis, given the characteristic rash and the proximal muscle weakness. Polymyositis, it has got similar presentation, but there is no characteristic skin findings. We'll also be thinking about SLE, but remember that SLE, we have a malar rash, and there's a muscle weakness as a characteristic rash, like a butterfly rash. Scleroderma can involve skin changes, but typically it presents with sclerotic skin changes, and rheumatoid arthritis, in which joint symptoms are more prominent than muscle weakness. So remember these 4 differentials. After you are done your history and your clinical examination, going to present the case. So here is one of the example. Mr. John Smith is a 45-year-old gentleman presenting with a 3-month history of progressive muscle weakness and a rash. He reports difficulty with activities such as climbing stairs and lifting objects. On examination, presentation, as I've already told you in my previous presentations as well, whenever you do the case presentation, start with the history and then you will go on to the examination. So in this case, on examination, there is evidence of proximal muscle weakness, and we have characteristic dermatological findings, which include a heliotrope rash on the eyelids and Gottron papules over the knuckles, and there are no significant joint symptoms or systemic features such as dysphagia or respiratory distress. And then on the third part on your presentation, we'll talk about some differential diagnosis. So based on the clinical presentation, my differential diagnoses include dermatomyositis, considering the characteristic musculoskeletal and dermatological manifestations. I have not mentioned here, but you can put here other differential diagnoses include polymyositis, rheumatoid arthritis, or scleroderma, or any other autoimmune disease like systemic lupus erythematosus. Then you will not stop here, and then you talk about the further investigations. Further investigations include muscle enzymes, EMG, muscle biopsy, and autoantibodies to confirm the diagnosis and assess for any associated complications. And finally, you will talk a bit about the management. So management involves a multidisciplinary team approach, including rheumatology input for immunosuppressive therapy and dermatological management of the skin manifestations. So in your presentation, the presentation is very, very important. So try to divide into different sections. Start with the history, examination, and then the differential diagnosis, investigations, and management. I put some of the questions here which are commonly asked, could be asked in your MRCP cases for this dermatomyositis. What are the characteristic features of dermatomyositis? Again, it's a repetition, so it is usually characterized by the proximal muscle weakness and distinctive skin findings. The skin manifestations include the heliotrope rash, Gottron papules, and erythema over the face, neck, and upper chest, which is called shawl sign. How do you differentiate dermatomyositis from polymyositis? While both they present with muscle weakness, dermatomyositis has also features which are characteristic skin manifestations like the heliotrope rash and Gottron papules, and these are absent in polymyositis. What other conditions would you consider in the differential diagnosis? Again, repetition. Differential diagnosis might include, we'll be thinking about polymyositis, we're thinking about the SLE, scleroderma, and rheumatoid arthritis. How would you differentiate dermatomyositis from SLE? Well, they both can present with skin manifestation and muscle weakness, but SLE typically they have an additional systemic features like serositis, arthritis, maybe renal involvement, which may not be present in dermatomyositis. What investigations would you order to confirm the diagnosis of dermatomyositis? So investigation might include, we'll be interested in doing the muscle enzymes, creatine kinase. We want to do the EMG muscle biopsy and autoantibody testing, and we'll particularly be thinking about anti-Jo1 antibodies. Treatment approach for dermatomyositis, well, we need a multidisciplinary approach, and we will be thinking about immunosuppressive therapies like corticosteroids and steroid-sparing agents like methotrexate or azathioprine, and dermatological management may include topical corticosteroids and photoprotection for any skin manifestations. So in the treatment approach, immunosuppressive and dermatological management. Remember these 2 points. What are the potential complications of dermatomyositis? Well, dermatomyositis the complications include interstitial lung disease. There may be dysphagia because of the esophageal involvement, or we may have a cardiac involvement which can cause arrhythmias or cardiomyopathies and malignancies, particularly in adults. How do you monitor this patient progress and response to treatment? So monitoring usually involves regular clinical assessment of muscle strength, skin manifestations, and systemic symptoms, and serial measurements of the muscle enzyme like CK, and obviously monitoring for any potential complications such as pulmonary function tests for interstitial lung disease would also be indicated. So that's all about the dermatomyositis. Remember, in the exams, I have noticed from the different candidates that they have difficulty in answering the questions, or when they answer the question, they don't feel confident and just give maybe one or two differential diagnoses and very short answers. So try to be more comprehensive and do the rehearsal of the potential answers which you're going to give to the questions. Thank you very much, and I'll see you in my next presentation.